Hi everyone. So this case is about intervaginal work and bladder post C-section restrictions and overexercising, and again compensating. So some compensations from these surgeries, this bladder fixation, if you will, resulting in compensatory strategies at the hip, resulting in some posterior hip pain, so a little bit of sciatica, if you will, into some pain down the front of her leg. So thinking about L4, maybe L5 nerve root. So she's getting some nerve root irritation. So I've worked with this patient in the past, and longtime figure skater for a lifetime. And initially when we started treating for back pain and coccyx, such compression at the coccyx into the sacrum. So we did do a lot of coccyx work, both internal, external, again, restoring those leg swings to the pelvis to get her out of lumbar spine. So she since has had another baby, and she's getting back into working out. And as she comes in today, hey Jen, I've got some trouble down my left leg. I feel like my hip flexor is always working really, really hard. And can you help me? So we dove right into gait, and it was actually beautiful because actually from the posterior aspect, she actually gets through her pelvis pretty well. Again, we've treated that. We've treated a lot of the extension through coccyx, sacrum, innominate on sacrum, innominate extension or an anterior rotation. So she actually did pretty well. Where I saw her was from the front. And as she walked from the front, it was all driving with her hip flexor. So she was not able to get into any anterior elevation at the pelvis, which is what we need for efficient gait, or else how else are we going to get forward? Again, the body's always finding workarounds to propulse us through space. And she's really overworking these hip flexors. So on top of that, she's doing this exercise program where she's bumped it up to 4 days a week, and it's a lot of resistance. She was doing some deadlifts. I said, we're gonna let those go for right now. Again, we've got inefficient mechanics, and again, it's not worth it. It's not worth it on an inefficient system to do that. There's many more things we can do that are less provocative in my clinical experience and personal experience. So, but the other thing we talked about, back to lunges, because I looked at leg swings, and again, she was struggling to get the leg swing, but it was more from the anterior aspect. So as she swung her leg back, again, from the front, it was soft tissues and or viscera, or it was an anterior inability to lengthen as she swung by. Again, as I mentioned, we worked all posterior over the past couple of years, and that's much better. But now I'm seeing, as she walked again, or as she did the leg swing, just so much lack of slide and glide through hip flexor, through peritoneum, not quite sure what tissues we're gonna get into just yet, rectus abdominis for sure. She's been doing a lot of core abdominal exercises as well. And she's also been working to support her diastasis. So, which she has felt pretty good. We've been watching that pretty closely. The other thing that we had noticed when she's standing was just there was a bit of, through the upper abdomen, just some bulge. And again, this girl, she's little, she's tiny, she's working out a lot. So, you know, why isn't she toning up above? Are the viscera not settling as they can? Because we got some scar tissue, 3 C-sections for this sweet girl. So looking at those leg swings, we absolutely need to restore those leg swings, because as she's getting her leg behind her, especially as she's doing lots of lunge work in her workout, she's getting shear forces at her lumbar spine. So, and then on top of that, she's not able to access her pelvis with gait, overusing those hip flexors. So again, that's kind of, here's what we need to unwind. I need to get those leg swings for her. So as I take her into side lying, and again, right, the posterior aspect was pretty good. Where we started to go for her, I said, very likely we're going pelvic floor. So again, trace and isolate. Where do I feel that restriction as I take her leg back? So hard for her to get into internal rotation anywhere through the hip into the pelvis. So I kept biasing, all right, where is she getting hung up with that internal rotation? So where we worked, how do we do this with you? She's in her side. She was side lying, and side lying that way. Very good. So here's my hands. So side lying, and I just wanted to feel what was going on pelvic floor, what was going on the base of the pelvis structure, what was going on pubic rami as her leg came into extension. And actually it was even more so as she brought her bottom leg, her left leg into flexion, as she pulled her right leg into extension. Again, there just was the inability for her pelvis to work in opposite directions, which again, we need for gait, we need for lunges, we need for cross-country skiing. So as I took her leg back, again, so much just between my two hands, like just a hard end feel. And it was hard for me to discern like what exactly is it, but I said, all I can tell you, and she could feel it too, like whatever we have in between my two hands, in between pubic rami in coccyx, again, the tissues below, you know, is it bladder? Is bladder stuck to uterus? Is bladder stuck to the anterior pubic rami? And as I say stuck, right, so here we've got pregnancy, of course, right? Pressure on tissues. We know how fascias change with sustained pressure over time. We also know how fascia changes with regard to inflammation, and she's had multiple surgeries and scar tissue. So there's many possibilities for tissues to become adhered together and lose the ability to slide and glide on each other. And again, the body's brilliant. It's not gonna let the bladder get tugged on, so how do we protect it? And or just the immobility from the lack of excursion itself. So as we start to work here, I'm coming in, I said we absolutely needed to get into obturator internus, again, thinking about our hips. So again, compensatory strategies. If her pelvis is not moving well, she's still moving through, so she's getting a lot of torque on the hips proper, right? So she's always torquing into external rotation. However, I'm not quite sure the mechanics in the fulcrum, but those hips were really sitting anterior. So again, however she was, again, you know, going through space with gait, in external rotation, extension, that's probably what it is, right? She wasn't able to extend well through the pelvis. So here is this fulcrum, if you will, this fulcrum at the hip that is held in some external rotation. It's also held in some external rotation. Again, she has been a figure skater forever. And again, lots of falls to the coccyx and to the cranium. So there is a significant dural tension component that sits underlying as well that we've addressed in the past. Didn't quite address it today, but it showed up just a little bit. So where I'm going with the story is, so I'm working bony contours, working trace and isolate. Where do I need to treat? Absolutely needed to treat through the obturator membrane as we work internal rotation and extension. I'm working externally, close on, but all along this pubic rami, almost on the edge, almost kind of external pelvic floor through the tissues of the pelvic floor. Coccyx was still present. Again, I've treated that several times before. It didn't feel like that's where I need to treat exactly today. It was more anterior pelvic floor. So as we're working, we treat both sides. I brought up to awareness, I said, I really do feel like we need to go internal. So we did, we went intervaginal, and she was supine. And I was most interested in what was going on the left pelvis into flexion, because that was where, even passively, as I take her into flexion, into rotation, adduction, she was really getting hung up. And just with what I felt externally and through the pubic rami and mechanically, in between my two hands, like it was deeper. I said, there's something deeper in the pelvic bowl that I need to get internal to access. So as we went intervaginal, there was a lot of tension. I had her right leg straight, left leg bent, because again, that was the position that I wanted to restore as much as possible. A lot of tension as we went interrectal, through the anal sphincter, through the tissues at the anal region. So, however, as she came into more flexion, they didn't tighten up as much, so I was not as concerned about that, because we can, as we work intervaginally, we can work coccyx, AP in that direction as well. So I knew that that was an option for me. I did work my way to the side, and I did want to flip because I wanted to know what was behind pubic rami, because again, my external work, again, such hard end feel. Again, the pubic rami just didn't have the ability to come into a rotation, right? This posterior rotation, this rotation of the, anterior rotation of the pubic rami, which is needed for the entire innominate to have this anterior rotation, innominate extension. So as we work intervaginal, we came in, right away I came into pudendal all along the ridge through here. So again, making sure pudendal was free, knowing that we've got some neural irritation down some of the spinal nerve roots, which were her symptoms down in her legs. So we worked through there along the ridge. And then as we worked our way, and it's challenging, I feel like sometimes once you're in there, you're not quite exactly sure what you're on. So I was coming into muscle fiber, and I do believe I was on the border. I was on the border of the obturator internus, which this doesn't show it that well. It shows it right, or like there's the edge there. So again, I could feel there's bladder right behind my fingers, and then whatever was starting to attach to the posterior aspect of bladder, obturator internus does, some of levator ani does as well. So again, those attachments, so there was just a lot of rigidity to those attachments, and then to the edge of the obturator internus. So and it also felt, as I was back there, I could feel the backside of bladder. So it really felt like bladder literally was stuck to obturator internus, stuck to the anterior pubic bone. So I am trying to literally free up that border of the obturator internus there. And then I also felt like I needed to work external. So I had actually, she was into hip flexion because that was the motion that I wanted to help her restore. So I'm working her into hip flexion, her legs on my shoulder. I'm intervaginal here. And I'm also working externally on the bladder because again, I needed to work both hands to help that bladder also have the ability to come into a rotation as she came into flexion again. Otherwise, everything was getting all jammed up in there. So then as we think about too, as we work intervaginal, we were able to get all the way back. I need to go into the anatomy books as far as what other anatomy do we have here. But again, the fact that she wasn't able to flex well, thinking about the nerve roots that come out of the sacrum, again, were they getting a little impinged or hit on the way down, thus the posterior buttock pain as well. So we primarily worked this left hip innominate flexion. So as she got off the table, actually, we didn't fully retest leg swings. She did, actually, she said they felt better. I didn't look at them so closely, but she was able to come into so much cleaner hip flexion and innominate flexion. So to be continued. So I said, we still need to get back in there, make sure those leg swings are there. But this was the biggest piece that we needed to work, was to help the internal organs of the pelvis, bladder off of obturator internus, bladder off of the pubic rami, so that she could have free mobility. So the other piece that showed up very significantly for her, every time she would laugh, I would feel her rectus pull on her pubic rami. So thinking about, all right, we got pressure systems and or as well, we've got length tension relationship. So as she laughs, here's all this pulling on her rectus abdominal muscles. And she's been doing a lot of work in her workout. Again, doing core, right? Which a lot of traditional core is working your rectus, which we know that isn't the actual deep stability of the core, which is what we need. So it was just interesting to me, and the fact that she did have a significant rectus, which diastasis that we've been watching closely. You know, we've been working pull down, stabilizing her feet, but she's kind of let that go because she's been doing her workout. So as we know, right, we've got our phasics, our outer strong muscles, and then we have our tonics. And it doesn't take much for us to lose the facilitation of the tonics and our phasics take over. And again, the exercises she was doing was really supporting phasic work and phasic stability. So she really has been working really hard phasically in her quads, hamstrings, and the abdominals as well. Even into pelvic floor, I said, give me a pelvic floor contraction, and her whole pelvis moved. So again, knowing she's really been over-recruiting for a long time. But where we took her, so again, mechanically, yes, we need to get her into mechanical efficiency so that she can fire these deeper stabilizers better. So we took her to the floor, and actually a lot of the work was starting to teach her how to let go of these outer phasics. And as she was on the table, I wanted to take her into basking seal, into anterior elevation, because that's what we needed. So mechanically, I still didn't quite have the range that I had hoped for her, so I still need to work on that for her. And it was really hard to get her to recruit, so I had to pull her arms, you know, let's come into a chop to try to facilitate the anterior elevation of the pelvis. Really, really hard for her again. Quads, hip flexors were like, bing, they're ready to help, they're showing up, they're ready for duty. So knowing we weren't gonna be successful in that position, I took her back into supine, which I had taught her before, but again, like I said, she's gone back into more of her phasic workout. But coming into hook line, engaging the ball, engaging base of support, ball of big toe. And for her, again, those quads are hanging on for dear life, right? So she is always overworking those. And that's just kind of how her body has worked and strategized for a long time. So for her, it was actually, we ended up working the chop pull down, and I had to come in super lightly. Excuse me, often I'll tell my patients, like, the stronger you are, the harder it is to tap into those deep stabilizers. So we were there a long time. And again, a lot of hers was I had her close her eyes to get out of her sympathetic nervous system and really work on letting go of her quads. Like, let the hip flexors go, let the quads go, let it come to you. So when I first resisted her, so she's hook line, she's coming down here. I'm giving some traction, because traction is what helps facilitate that core as well. Traction is the glue, right? She originally, at first, I just felt it was just all shoulders. It was all shoulders hanging on for dear life. So, and I wasn't able to give her much resistance. So as I continued to hold traction, I had her back off in the engagement of her feet because she was over recruiting everything so much. So I just held lightly, and we just waited, and she just worked on relaxing And the more she was able to let go, like you can feel, like when you get that feel for it, you can feel for, here's where she's working in the shoulders. She continues to hold. Okay, I feel it come in. Now you're in your sternum. And she could feel that. Can you feel that? I do feel I'm there now. And then I'm able to hold her a little bit. I'm able to give her a little bit more resistance. So the longer we hold, hey, now you're down into your belly button area. Can you feel that? And she could. So again, our goal is to get, right, the summation of fibers, that core recruitment all the way down to that pelvic floor without over recruitment of all the external, the phasic. So she did a great job getting into that. So that really is her homework, is just taking the time and letting go while she starts to build that inside out. So it'll be very, very interesting, again, as we work with pressure systems, how that, excuse me, rectus diastasis does, as we start to get her back into her true